phototherapy. A very nice study that was done now over 10 years ago, 28 kids ages 7 to 17 at 2 sites in Boston and Washington, D.C. It was a double-blind, placebo-controlled crossover design. They got 1 hour of bright light treatment in the afternoons and 2 hours of dawn stimulation. And they looked at total depression, atypical depression, meaning like the oversleeping, overeating, and the typical depression scores, the kind of other kinds of symptoms of depression, all improved with phototherapy. 78% of parents and 80% of children reported that the phototherapy portion of their treatment was their best condition compared to the placebo condition. What we have kind of gravitated towards, so this is one of the only studies that's been done of phototherapy in kids, are general clinical recommendations. And again, in Miami, you're not going to feel it because we send our kids to you for college. Okay? So when our kids are getting to those later years in high school and they've really struggled with a seasonal mood disorder, we say, where are you applying to college? Have you thought about Miami? Okay, so we are sending them to you. We're sending them to Arizona, to New Mexico. That's where we send our kids. But if you live up north in a gray belt area like I do, you will advise kids to sit 20 to 40 minutes once or twice a day in front of a special phototherapy lamp with the right lux, which is how we measure that light, so that there's not eye damage, no other kinds of difficulties with that, and it's a beautiful intervention. ECT creeps people out when they hear about it, but in my household we have strange conversations, and my family all knows if I ever develop a really bad psychotic depression, I don't want a bunch of failed medication trials, I want ECT. Okay, so odd family conversations. Epidemiologic study done in New South Wales and Australia of all adolescent ECT, completed over a 6-year time period. They had 42 patients, and their results really mimicked the adult literature. Half had marked total improvement. Patients with mood disorders derived the most benefit. Side effects were transient and minor. Comorbid personality disorder predicted poorer response. It would predict a poorer response to everything. And propofol, which is an anesthetic, was associated with shorter seizures. The practice parameters from the Academy of Child and Adolescent Psychiatry published 7 years ago. ECT is the treatment of choice for adults who are pregnant, catatonic, have neuroleptic malignant syndrome or other medical conditions that contraindicate standard medication regimens. We would believe that that would also most likely hold true for youth. We have limited case studies, but it indicates that ECT is beneficial for youth with mania, rapid cycling, and the depressed phase of bipolar disorder. It's not an easy thing to do. You have to have 2 board-certified child and adolescent psychiatrists independently review the records and say, you know, the next thing to try, you have to have at least 2 failed medication trials that were well done. And then they have to both independently say, you know, if I were treating this kid, I would try ECT next. So it doesn't come easily. It's uncommonly used. We probably do a half a dozen cases on our inpatient unit in a year. We've got a big catchment area, 20-bed unit. It has potential for adverse events, but it often provides significant symptomatic relief. And if you've ever watched somebody who's gone through ECT in just an intractable depression and get out of it and have their brain clear, it makes you think, you know, you might lose a little memory, but you got your life back. Okay, doesn't happen all that often, just like to put it out there. Nutritional interventions. I'd like to talk a bit about this and focus on 2 different areas, omega-3 fatty acids and a multi-nutrient complex. Let's think a little bit about omega-3 first. What do we know about changes in dietary omega-3? Back in the hunter-gatherer days, you know, thousands of generations ago for us, the omega-3 to omega-6 ratio in the naturally occurring diet was 1 to 1. The modern ratio is more like 1 to 100 or greater. Less than 10% of adult Americans obtain sufficient omega-3 in their diets, and the rates are worse for children. What do we know about treatment? Nemitz et al. Published now 5 years ago a trial of 28 children ages 6 to 12 with major depression in a 16-week randomized controlled trial. 13 were on omega-3, and there are 2 main questions that we don't know about with omega-3. We don't know the most effective dose, and we don't know the most effective EPA to DHA ratio. But you don't just want to run out to CVS or Walgreens and take anything that says fish oil. You want to look, and for me I have to put on my special reading glasses, the little tiny print on the back of the bottle, what's the EPA plus DHA? And you want that to be probably somewhere between 1 to 2 grams. And I say probably because that's our best guesstimate based on the limited data that are out there. So you probably want 1 to 2 grams, and we don't know the best ratio of EPA to DHA. This study used a 2-to-1 ratio. The next study I'm going to show you used a 7-to-1 ratio. 8 kids were dropped out of the study and were deleted from analyses, 5 from placebo, 3 from omega-3. Nobody reported any clinically significant side effects. There was a greater than 50% reduction in depressive symptoms, 7 out of 10 in the omega-3 and none in the placebo. Remission, full remission from the depression, occurred in 4 of the kids on omega-3, none of the kids on placebo. Most of the response, this was a 16-week study, and almost 100% of the benefit that was seen by week 16 was already seen by week 12. Findings support omega-3 as potentially beneficial for childhood depression. It's one study. The risk-benefit ratio may be superior to that of traditional antidepressants. So it's something to think about and consider and talk through with families. There's been one trial in bipolar disorder in children. It's a 8-week open-label trial. They used, again, a 7-to-1 EPA to DHA ratio. It was monotherapy with the exception of if kids came in with comorbid ADHD, they could be on stimulant. 20 outpatients, aged 6 to 17, with diagnosis somewhere on the BP spectrum. Their dosages were widely varying, anywhere from 1.3 to 4.3 grams per day. 85% were taking 2 or more grams a day. But you can't, even in reading the study very carefully, you can't quite get exactly what those doses were. 16 participants completed the entire trial. Dropouts were due to lack of efficacy, not side effects. Omega-3 caused very few and mild side effects, usually like GI, you get little fishy burps, but that was about it. Manic symptoms decreased by 30% in half of the kids and decreased by 50% in a third of the kids. So if you think a third, half, a half third. Those on 2 grams or more seem to improve more than those on less than 2 grams. So that's where we get that maybe 1 to 2 grams. We're not quite sure what the dose should be. Depressive symptoms, 40% rated much or very much improved. So this suggests to me within the bipolar category, it's probably not going to be enough to fully manage, but there was a sizable chunk of the variance that came down. So then if we think about how do we think about combination treatments, if it can bring down how much psychotropic medication we need, or potentially psychotherapy that could boost results, will this be enough for some kids? Or can you get by with less medication if you're on omega-3? Are some of the questions that this study makes me think about. Okay, so just tuck away those little omega-3 facts. We're going to move on now to kind of a broader nutritional intervention. And this is a very busy slide, but it shows lots of different nutrients, vitamins, and minerals, and their potential effect on brain, central nervous system function. Past nutritional research has focused on individual vitamins and minerals, but we don't take food that has, you don't eat an apple and get just one nutrient. You get a combination of nutrients. There's no one food product that only gives you one kind of nutrient. So to understand results, we need to know the potential mechanisms underlying the positive effects of nutrients on mood. There are at least 4 possible explanations for how this might be beneficial. Mood dysregulation may result from innate metabolism malfunctions that ultimately affect brain function. Mood instability may result from deficiencies in methylation of molecules responsible for completing DNA transcription. And our whole understanding of genes and DNA, it's not just like a static thing. This stuff changes all the time, and our understanding of it in the scientific field is changing very rapidly. Switching on genes, regulating protein generation, activating enzymes, synthesizing neurotransmitters. We're gaining, from a basic science perspective, a better sense of what's going on in that world. And then how we understand that from a nutritional vantage point, I think this is an area that we're going to have tremendous growth over the next 10 to 20 years. Nutrition deficiencies may alter gene expression and lead to mood instability. Unstable mood may result from long latency effects of nutrition deficiencies that alter brain development directly or by way of dysfunctional nutrient absorption. We know that diet and nutrition affect the structure and function of the brain. In adulthood, the brain contributes about 20% of the human basal metabolic rate. In neonates, this goes up to about 44%. So, the brain is very busy using up what we give it. Nutrition deficiencies, particularly in the prenatal and neonatal stages, may contribute to long-term physical and behavioral detriments. So there's a little background. Now let's talk a little bit about what studies have shown us. A very interesting study done on 468 6 to 12-year-olds from 2 working-class, primarily Hispanic elementary schools in the southwest U.S. It was a randomized control trial. Half got placebo, Half, and talk about low-level intervention. Half of these kids got a daily vitamin mineral supplementation at 50% of the US RDA for 4 months. And let me tell you, as I've started getting into this whole nutrition area, this is a whole other area where we have so little science. We don't even really know what the recommended daily allowance is based on for so many things. And we don't really know what the upper limit, the safety limit is for most of our nutrients. There's so much that isn't known relative to what's known. It's kind of amazing. The outcome variable that they measured were disciplinary infractions at the school. And what they found, the vitamin mineral group had, compared to the placebo group, 47% lower mean rating of antisocial behavior. All they got was like a half-powered vitamin mineral daily. Lower ratings for every type of recorded infraction: threats and fighting, vandalism, disrespect, disorderly conduct, assault and battery, defiance, obscenities, refusing to work, endangering others, and non-specified offenses. So that's a very low-level intervention that packed a pretty decent punch. Now, looking at adults with antisocial behavior, Gesh and colleagues have done a number of studies in prisons, and this is fascinating to me. Double-blind clinical trial, 231 prisoners, 142 days on recommended daily doses of 2 supplements in this case. 1 capsule of Forceval, which is a 25-ingredient vitamin supplement, so a multi-nutrient. And then 4 capsules of FML marine, which is, again, fatty acids, containing, you see the amounts of linoleic acid, gamma-linoleic acid, EPA, and DHA, or placebo, and they had nice comparable pills. Neither group reported notable side effects. The group getting the active supplement experienced a 26% decrease in overall infringements, resulting in disciplinary reports compared to the placebo group. So you get a quarter reduction in bad prison behavior. To me, that's an important outcome. Okay, now on to the nutrient that I'm going to provide a number of study data on and some of the work that we've done at OSU. EM Power, which you can find more information about at truehope.com, contains 36 ingredients, lots of vitamins, you see them listed there, lots of minerals, and then some other antioxidants, etc., some herbals. We have 1 animal study. Newborn rats received a frontal or posterior parietal lesions on day 3. Subsequently, they were fed either normal rat chow or rat chow enhanced with a rodent-appropriate dose of EM Power. And at day 60, the supplemented animals compared to the unsupplemented rats experienced deficit reversals. So they were putting them through behavioral kind of tasks, cognitive tasks for little rats. And they did better on spatial learning. And then when they sacrificed them and looked at their brains, they had significant greater regrowth of cortical tissue. And behaviorally, before they sacrificed them, they were significantly calmer. Okay. So that's nice for rats. What do we know about people? I'll go through some of the adult studies first and then move on to the child studies. In the first open label adult study that was published, 11 adults aged 19 to 46 diagnosed with bipolar disorder who were resistant to conventional treatments. Treatment occurred for 6 to 21 months with no restrictions on medications. They could continue to use whatever they were using under the supervision of their local psychiatrist. And the outcome variables were very standard measures: the HAM-D for depression, the Young Mania Rating Scale, a standard mania scale, and then the BPRS for looking at other accompanying symptoms. What they found was a 55 to 66% reduction in depression, mania, and psychosis, 50% decrease in need for psychotropic medications, and the only mild side effect reported was infrequent and transitory nausea, which occurred most commonly when participants took their supplement without food. I don't know about you, but I can't take my vitamin in the morning if I don't take some juice or something, food with it. It's very easy for that to disrupt the stomach. Conclusion, you need more studies. 1 open label trial won't convince anybody, definitely. Okay, what do we know about kids? Dr. Popper, 10 years ago, gave the first child study of a 10-year-old boy with bipolar disorder who went on to an ABPP design. The A condition, for 4 months, they reported very daily severe temper tantrums that went on for hours on end, plus the other associated features. The B condition, he had 2 days after his full EM Power dose, his behavior improved significantly. By 5 days, there was no more witnessing of behavioral tantrums or mood irritability. Then they went back to the A condition. After 14 days, they discontinued the EM Power. Within 2 days, the tantrums were right back to where they'd been before. Then the family was traveling and didn't have access to the EM Power, so they went to a health food store and kind of concocted their own supplement that kind of mimicked what was in the e-Empower, and that resulted, according to the parent and teacher report, about a 60% of the benefit that they saw on the e-Empower. When they were able to get the e-Empower back again, they went up to that full kind of recovery that they had noted the first time. So an ABACB design. Then Dr. Popper got pretty excited about studying this a bit more, had 22 patients with bipolar disorder, 10 adults, 9 adolescents, 3 children. Again, mild side effects. Most of them, 86%, responded positively. 73% previously on psychiatric medications remained stable without resumption of these medications at both a 6 and a 9-month follow-up assessment. Again, this is still all open label. It's something, it's not everything you would want science to be, but it's giving a signal of we ought to look at this a little bit more. Dr. Kaplan then reported on 2 boys with irritability, mood lability, and explosive rage. An 8-year-old who had atypical OCD and ADHD. She did an ABAB design. The A was baseline, and then the second time around was the EMP withdrawal. And during both of those A periods, there was consistent explosive rage, irritability, and a very scary obsession with guns. That was very terrifying to treat. The B condition on e-Empower, these behaviors almost completely dissipated, obsessive thoughts ceased, the frequency and duration of temper outbursts decreased significantly, mood fluctuations minimized. After more than 2 years on treatment, the boy remained well and free of side effects while taking only 25% of the original e-Empower dose. Then she published a case series of 11 children, 8 to 15, all with mood and/or behavioral problems. Intake diagnoses you see bipolar, Asperger's, ODD and anxiety, kind of a host of disorders. 82% completed the open label trial. Using intent to treat analyses, again, the most conservative, where you take all of the data from all of the kids, even the dropouts, indicated significantly decreased scores from baseline to final visit on the Youth Outcome Questionnaire and the Young Mania Rating Scale. And for the 9 completers, improvement was significant on 7 out of 8 Child Behavior Checklist scales, the YOQ and the YMRS. And the conclusion was, we need RCTs. Open labels are great. They're giving a signal. We need to study this in an RCT. A case study that we reported, and this was just phenomenal to me. This is a child I had originally diagnosed just before his 6th birthday. Initially, we gave him BPNOS and had to rule out of GAD. He had severe mood cycling, sadness, irritable, self-harm, sleep disturbance, very bad tantrums, elevated mood, lousy peer relations, didn't have any friends, very low frustration tolerance, flight of ideas, aggressive, hyperactive, impulsive, negative behavior. Didn't look so good. Again, family history, bipolar on one side and depression on the other. By age 8, his diagnosis had evolved into BP1. He'd had a full manic episode. He was anuretic. The GAD had been confirmed. He also had a learning disability. And his behaviors were just getting worse and worse. He had some transient suicidal ideation, and overall his impairment was worse. By age 10 to 11, he had developed very clear psychotic features, auditory hallucinations. He had very distinct obsessions and compulsions. He was increasingly disrespectful. I'm going to come into the medication history in just a minute. Yeah, it's okay. Great question. And this was a mom was homeschooling, kind of, again, very strict standards, very tightly run home, very competent mother. And this kid was just flailing out of control. Intrusive command hallucinations when he was anxious, told him to act on his compulsions, do things he didn't want to do. He was being threatened about 100 times a week. If you don't do this, you'll surely die. And the thing he was supposed to do was really not good. Don't do this, referring to parents and other adults. In 2006, the voices told him he would die on the day that John Glenn dies. Not a common thought for like a 10, 11-year-old boy. Symptoms became incredibly impairing. He was removed from from his private school, which was a very gentle kind of an atmosphere, and started being homeschooled. Throughout that time, he was receiving conventional treatment. Medication, I was providing the therapy. I would like to think I was doing a decent job. The medications, he was going through very standard, methodical medication trials. He was very side effect sensitive. He had intolerable side effects or inadequate treatment response, or both. And he had been on about everything that we had to try. Nothing maintained his symptom amelioration and adequate global functioning. He might get a little relief for a couple of months, and then he would fall apart again. So he was very, very treatment resistant. And then we started, so the The story behind this, we were trying to get an open label trial approved at OSU. The IRB was taking absolutely forever. Mom comes in to see me in December and kind of sheepishly pulls this bottle out of her purse and said, "Have you ever heard of this?" And it was the e-Empower. I said, "Well, funny you should ask. We're trying to do a study. Just waiting for the IRB approval. As soon as we get it, you can be the first family to enroll." Well, then there were pauses. We weren't getting the approval. So finally I said, "You know what? I don't know if or when they're going to let us do this study. Just do it by yourself. And if you don't mind, tell me how it works." Well, she was happy to keep telling me how things were going. So we tracked. So this wasn't a study. I wasn't controlling anything. She was just doing this on her own with the company. So he begins e-Empower. He starts tapering off all of his medications from December to February. And you see he's ramping up on the e-Empower. He was on lithium and Lamictal, and he was kind of methodically cutting back on that. And what seems to happen with this nutritional intervention is that it potentiates the medications, so that if at a certain level of medicine you were doing okay, when you get the nutritional intervention, you start to have side effects on the same dose. So you have to be cutting down the medicine while you're ramping up on the other. So it's a very kind of balancing act that goes through. And what happened in a very rapid period of time, what we found was that by May, within a couple of weeks, he was responding beautifully to the treatment, got completely off the lithium and Lamictal. About 3 or 4 months later, he had to increase his dose from 15 to 18 capsules. It's a lot of pill swallowing, and they're kind of big. So if you've got somebody who just cannot swallow pills, there's now also a liquid formula or powder that you can mix into liquid. We haven't used that because we can't do studies with it because it's harder. We don't have a placebo for it. So he was on capsules up to 18 a day because his irritability and mood cycling and kind of odd behavior had increased. He went up to 18, came right back down again. That summer he went back down to 15 capsules. That fall he started regular public school for the first time ever, played on the school sports team, maintained friendships. His parents reported improvement in his functioning. While taking the supplement was greater than he'd ever had on any of the psychotropics. And his only additional intervention had been drinking whey protein mixed in milk when he was really active. This is a really gifted athlete, and sports seasons really matter to him, so he really needs to be functional. And once he would take the whey protein, it would keep him, as Mom said, cleared, slowed down, peaceful, settled, and happy. These were not words I'd ever heard in 6 years, him being described as peaceful. The following summer, he continued to remain stable on a normal teenager dose. And I just talked with the mom this summer. His symptoms started emerging again, and they needed to go back up to 18, and then he was fine again. I gave grand rounds at OSU when he was about a year and a half into the treatment, and I hadn't seen him in all this time. Mom would send me email updates of how he was doing. And for the first time ever, a lot of our kids, particularly if they get to the level of having psychosis, it's almost like they have a little sign stamped on their forehead, "I'm a child psychiatry patient," that they kind of wear everywhere they go. And they just kind of look a little off. This kid, for the first time ever, he comes in with his mom and dad to grand rounds. He looked like your typical junior high kid. He's this handsome, good-looking kid, had his baseball cap on, had his jeans on. He just looked like a regular kid, and he functioned like a regular kid. I have not seen him since then. Mom keeps sending reports of how he's matriculating now through the end of high school, doing beautifully. Nothing but this. It's kind of amazing. So that kind of it makes you think, wow, I've now seen this with my own eyes, 6 years of conventional treatment, switching over to a nutritional supplement, best he's ever done. We did an open label trial. This is now in press with the Journal of Complementary and Alternative Medicine, and of 10 2-month open label trial of e-Empower. We wanted to look at the feasibility and provide some preliminary efficacy data. This was Liz Frazier's thesis. She's on internship right now, and you'll hear next a little bit about her dissertation. Participants had to remain off all of their psychotropics for 11 weeks. We had a 3-week washout of anything. If kids came in on a cocktail or single medicine, they had to go off it for 3 weeks before they could do our study. Then they had 8 weeks of e-Empower. Psychosocial treatment could continue. We did 7 assessments with the parent and child. We did a brief physical exam, and we did blood draws at the first and last visit. 10 kids between the ages of 6 and 12, average age about 9. 6 of them were boys, 9 white, 1 Hispanic. IQ estimate was around average. Income ranged dramatically. We had 1 child with BPNOS, 1 child with BP1, 3 with BPNOS, 6 with that subthreshold BPNOS I was describing, but of those, 2 had MDD and 1 had dysthymic disorder, and the other were kind of in a mood NOS category. They all had a comorbid behavior disorder. 6 out of the 10 had comorbid anxiety, and 1 boy was anoretic. 7 of the 10 completed the full open label study. They started on 1 capsule 3 times a day, increased up to a maximum of 5 capsules 3 times a day. They averaged 46.5 days. They could be on no concomitant psychotropics. 3 had come in on cocktails and had to be weaned off and complete that 3-week washout. 1 came in on omega-3 and melatonin. They had been on that for a long time, and they just stayed on that throughout the study, so the only change was the supplement. 1 came in on omega-3, and Focalin at 10 milligrams was added after visit 5, which was a lower dose of Focalin than he had been on before the study. And then all 10 had been in psychotherapy. It had been long-term, long ongoing, and they kept maintaining their psychotherapy throughout the study. Side effects were very minimal. 4 had mild nausea if they took it without food. 1 vomited 1 time when they took it without food in the morning. 3 had mild initial insomnia. You can't take your last dose too close to bedtime, or sometimes there can be trouble falling asleep. 1 reported mild increased appetite, and 1 kid wet the bed once, and the mom said, "I'm sure this has nothing to do with the supplement. He does this from time to time, but we recorded it." Here's the intent to treat analysis. So this is even including the data from the 3 kids who dropped out pretty early in the study. So this is when they came in for their baseline. Here's where they get their first dose of E-Empower, and you see their depression scores came down. It was a P of 0.06 for 10 kids. So that's pretty good. Clinically, it was a significant difference. Statistically, it was an almost significant difference. If we look just at study completers, you see a more robust response, as you would expect, and that was clinically and statistically significant. The mania rating scores, again, starting with the intent to treat, the more conservative analysis. Here's where they get their first dose of E-Empower, and you see that dropping significantly and more dramatically if you look at study completers. Okay. So 3 kids dropped out due to tolerability, palatability, compliance issues. 2 of the kids really from the get-go weren't going to take this. They didn't like swallowing pills. Their parents had tried to talk them into it. They said they'd give it a shot, but they really didn't want to do it. 1 kid got very oppositional partway through the study and dropped out, and the parents put him back onto standard psychotropics. So our conclusion from that is those who fit the swallowing inclusion criteria, if you have a little bit stricter criteria about who you'll enter into your study. So now we do practice swallowing before we start anybody on any study that requires swallowing any kind of a capsule. And if you can't swallow it after we go through we have a very cute training program that we put kids through to get them to swallow. If they can't swallow the capsules, we don't let them enroll because they're not going to be able to do the study. So, treatment response, it suggests that depression and mania symptoms seem to decrease over time. It's an open label design. It's 10 kids. We've got to be very cautious in terms of how we interpret it. We know that placebo effects are fairly common. Anecdotal follow-up, we know that 4 continued on E-Empower post-study completion. 2 were considering it. They weren't sure if they were going to spend the money. It's $100 to $200 a month if you're paying cold cash to get it. 1 began a mood stabilizer. The 1 who dropped out about halfway through the study started an antidepressant. 2 we didn't have follow-up data on. Those were the 2 who dropped out right away. So it suggests that we really need a placebo-controlled trial, standard RCT of this. So Liz has done, so the student who did this for her master's thesis is just now finishing up an ABAB blinded study of SMD, looking at the E-Empower. We don't have any results analyzed yet, so I cannot even give you a hunch of how that study is going, but she's just about finished with her data collection. Okay, and with that, I kind of made up time, I think. So what kinds of questions do you have on biological interventions? And then we will take a break for lunch. Any questions? We looked at, so the great question, would this work for kind of any child? Is it specific to mood dysregulation? Not sure. Some of those early case studies that I showed you, the kids had a potpourri of diagnoses. There was always some affective instability in any of the kids who got put into, for example, the Kaplan open label trial. In Liz's dissertation, we're looking at kids with SMD. So many of them had dysthymic disorder or major depression, and then kind of bad ODD, ADHD. We'll soon learn how much it helps those kids. There were kids, again, in the open label trial whose anxiety scores were coming down, so I'm not sure what else it might hit. And we really wouldn't have enough data to be able to talk to you about that. What we recommend when people are considering nutritional interventions, particularly, for example, with the Empower, I would say if you've not tried medicine yet and you're really scared, and understandably, you've got some hesitancy because of the potential side effects. And we don't have long-term data on the atypicals. We do have some reason to believe that if you stay on an atypical, you are at risk for developing metabolic disorders, type 2 diabetes. That's not good. So we have some reason to be cautious. You don't want to just throw medicine at anybody without good reason. So if you're skittish about starting medicine and you haven't tried yet, that's one reason to try this alternative. If you've been on medicine, like my case study that I reported, for 6 years we gave it our best shot and he never really did very well. He got maybe 75% better for a while and then he would, fall back. So that was a child who was not succeeding on conventional interventions. That's another reason to try it. If somebody is stable on their psychotropics and they're just thinking, oh, I wonder if nutritional interventions would work, I would say, leave it alone. You're doing well. Don't rock the boat. I'm delighted you're doing well. If something goes wrong and you stop doing well, then come and let's explore this. But I would never want to rock the boat with somebody who's doing well. So I'm really careful and cautious about that. But as now that people are finding these publications, I'm getting these sort of random calls from people, do you advise in my situation to try this? And I'll just kind of send them back to the website and say, do your own exploring if your comfort zone is there. So I just had a mother who both parents are primary care physicians in another state who had emailed me inquiring about this, had read the article, wanted to know more. I said, given what you're describing to me, this is something that's definitely worth you exploring. Just got an email from her this past week. Her child who'd been on a very substantial cocktail, had not done well, has now gone on to this and is looking, just like my case study kid, looking the best he's ever looked and he's on no psychotropics. That's an anecdote. It's a case study. I don't know if this kid did it and responded beautifully. For all I know, there are 100 kids who didn't. That's why we need an RCT. I'm impressed with what I'm seeing anecdotally, and it makes me want to have more science. Okay. Any other questions? No. So in our study, in the N of 10, 3 kids just wouldn't take it. Well, 2 kids wouldn't take it. 1 kid refused halfway through and the parents yanked him and put him on antidepressant. So would he have responded more? I don't know. But the other kids all got, if you looked at each single case, they all were getting better. We also looked at dietary records, and their diet did not change in any meaningful way over those 8 weeks. So it wasn't like somehow they were eating terrible food and now they're eating really healthfully. It wasn't a dietary change. We looked specifically at vitamin mineral levels within the body. Some changed, some really didn't. And the difference if you're water soluble or fat soluble, where the changes really were. But those were not dramatically associated with clinical outcomes. So we don't fully understand the mechanisms, but it's kind of one of those curiosities that I want to understand it better. And I'm hoping in the next 10 years we make some advances in the science. So for those of you who were here yesterday, we have 2 studies where we're looking now at omega-3 and psychotherapy. There is less skepticism in the scientific review groups for omega-3. When you present this multi-nutrient ingredient, people go a little bonkers when they review it, and they say, well, it's got 36 ingredients, what's the active one? I don't know. I actually don't think it's one ingredient. I think it's probably a combination, but I couldn't tell you. You could spend the rest of your career dismantling those 36 ingredients. So, and you might never get to the answer, because when you start doing the mathematics of how many combinations you could have of 36 ingredients, it goes on a long way. So it's harder to get a funding agency to fund you. We've been kind of looking for funders, but it takes longer. It took longer to get the IRB approved for Liz's master's thesis than any other study I've ever done, ever, in any setting. Kids can be on psychotropics, but getting an IRB to convince them that you can do a multi-nutrient, that took us a long time. So It's hard to do the study. I could not have launched my career with this, or I would no longer be an academic psychologist. I would be doing something else because I would never have gotten funded. I would never have gotten tenure. Now people might think I'm nuts, but maybe not just because of this. You know. So is it contraindicated to do all of the above? It appears on e-Empower that psychotropics are potentiated. So you have to be very cautious. If you've been on psychotropics and you're going to ramp up on e-Empower, you really need to come down on your psychotropics, or you may end up with side effects that are seemingly caused by the now bigger bang of the psychotropics. We don't have reason to believe that that happens with omega-3. So there was the one study, if you recall, Gesch's study in the prisons in Great Britain, where he was doing a combination of fish oil plus a multinutrient. And he was doing both at the same time, and that's where you got the quarter reduction in infractions in the prison system. So that combination probably is good. The very first grant that we tried to submit to NIMH was looking at e-Empower and fish oil, and in a 2x2, so you could look at the combination and the unique effects. And they very politely told us we were nuts. Not even all that politely, to tell you the truth. So, you know, I've got a thick skin. I don't mind going back. I've been rejected so many times in life. I can be rejected again. That's okay with me. I'm pretty used to it. But it's hard to get the funding. So it's hard to produce the science, and then people turn around and say, but there's no science. It's like, well, give me money, I'll produce science. If it doesn't work, I care as much about telling families that it doesn't work if it doesn't. People have time, money, and hope. Tomorrow always comes, and that gives us more time. Another paycheck eventually arrives, and there's more money. But when we use up hope, it's gone. And I don't want to use up people's time, money, and hope. I really don't. So if I find that this is really bogus, when I do real science, we really run a couple of RCTs and we don't get an effect, if that happens, then I want to tell people don't waste your money. But if we do an RCT and we get signal and we start to look at the mediators and the moderators and we figure out for whom is this treatment really beneficial and who's going to need something different, that's what I want to figure out. And my guess is it's going to be in that mediator-moderator level of it's going to work really well for some people, but it's not going to do it for other people, and why is that? That's what I'm hoping we'll get some funding. So if any of you like win the lottery and want to give us money, you just let me know. I'll take it. Be very grateful. Yes. They were having whatever diets they were having. In our study, I can't comment on the other studies because not everybody has done kind of full or reported on full dietary habits. Our N of 10 went from really nice nutrition to kind of your average everyday nutrition to you eat hot dogs at every meal. There's one kid who ate hot dogs at every meal. It's like, ugh. So a wide variety within an N of 10. But you couldn't say it was all because of horrible nutrition. But we don't know if in a mood disorder or another condition, if some kids are really just processing the food differently, if the metabolism is different. We don't know. We know that medications get metabolized differently in different people. We don't, there's more that we don't know than we know in this area. Okay, psychosocial treatments for bipolar spectrum disorders. We'll talk about some general principles and multifamily psychoeducational psychotherapy and individual family psychoeducational psychotherapy. This is the treatment manual that we just published with Guilford this past spring. If you get this book, you'll have a lot of the handouts that are in the workbooks attached as appendices. We also have workbooks for both MFPEP. We have the parent, the child, and the therapist workbook. We also have for IFPEP the parent and child workbooks. So I would encourage you, particularly if you're running group, it's nice to have the treatment manual that really fleshes out in a lot more detail the kind of the content of how we do therapy and why and the nuts and bolts of it. But particularly if you're running group, it's really nice to have all of the worksheets all organized in a handy-dandy fashion. So I would encourage you to think about getting those workbooks. It's also useful, I think, in IFPEP because then you're giving the family really a thing. Like, this is a very legitimate treatment. There's a booklet that we're going to work through together. So it kind of makes it all more real and tangible, I think. But this book will give you a lot of the how-tos and the thinking behind it. So what is the thinking behind it? So our orientation, as you might guess, is very much a non-blaming, growth-oriented kind of a model. Definitely have a biopsychosocial conceptualization of bipolar disorder. Our therapeutic techniques are family systems and cognitive behavioral based. As we go through the workbooks together this afternoon, you'll think, that's not new, I know how to do that, and that's the correct thought. There's very little that I will talk about, if anything, that you'll say, I have never thought to do that before. I've never thought about using problem solving in a therapy session. I imagine you've done all of these things, but it's putting it together in an integrated package and helping the families understand the whys that I think is very beneficial. It was our expectation that when we provided families with education and support and skill building, it would lead to better understanding of the disorder. If there's better understanding of the disorder, it should lead to better treatment and less conflict within the family. And if that happens, you should have better outcome. There are 3 formats. Yesterday in the keynote, I gave some of the data around that, which I won't review again today. But basically, we found that this treatment works, and it works really precisely in the way that we thought it would. So we have the MFPEP, the IFPEP, and we've also done workshops for our inpatients. So how do we want to conceptualize family-based intervention? Historically, families have been blamed. And still currently, we see that. In the MFPEP study that we did with 165 kids with mood disorders, I felt like a clinical voyeur because we were only providing this adjunctive 8-session group, but we were very carefully and meticulously measuring treatment as usual. And we were hearing about, granted, we were hearing from the parent's perspective and the child's perspective, but after all, they're the consumers of the care. We weren't hearing directly from the therapist, so I don't know what the intention was, but I heard some very painful stories of what was going on in the name of therapy. So we had a child who stripped naked and ran screaming through the house when manic. And what the parents reported to us is that they were basically reprimanded by the therapist when they came back to the next session because they weren't following the behavioral plan. That's not a behavior that's supposed to happen. We agree. That is not a behavior that is supposed to happen. But kind of reprimanding the parents for poor behavior management is probably not the most adaptive strategy you can use in therapy. We had a little boy who was suicidal and ran out in front of traffic trying to get killed. The family was also reprimanded, according to the parents, for not ensuring the safety plan was in effect. That's not very therapeutic. Okay? These families are in intense pain, and we've got to come up with a more useful strategy to help them and support them and build the skills they need to manage the symptoms. So families have not gotten useful information, support, and skill building. And if they look skittish or in our fancy clinical term defensive, no kidding. I would be too if somebody was telling me that my child had horrible, severe psychic pain and it was my fault. I would be a little defensive at that point. Okay? So we really don't see it as the family's fault. So what are the goals of psychoeducational psychotherapy? We teach parents and kids about the child's illness and its treatment. When I got my very first grant to study this from the Ohio Department of Mental Health, I went home and I was telling my husband I was so excited because we got this grant. He's a pediatrician in primary care. So he's saying, trying really hard to be a good supportive spouse. Well, now tell me again, what is it that you do? I said, oh, it's so exciting. We teach the kids and parents about their symptoms and how to manage it. He said, isn't that what you do in therapy? Now he's thinking diabetes education, asthma education. It's what all the pediatricians do with their kids all the time. It's like, it was so straightforward. It's like, oh, honey, don't ask what we do in therapy. You don't want to know. Not good, not good. So we teach just fundamental skills. We would not let somebody become a psychiatric aide on our inpatient unit without teaching them about how to manage suicidal behavior, without teaching them how to manage out-of-control manic behavior. And yet we expect our families to manage that behavior in the children. Now, what's that about? Okay? We provide support, particularly in the group format. Kids are meeting other kids. Wow, you're on Abilify too. I've never met anybody on that medicine before. Parents look around the room and say, oh, you don't look like a child abuser either. How about that? You know, that's so nice. Their struggles are so different from a typically developing kid's struggles. Okay? And suddenly you're in a room filled with people just like you, no matter how many other differences there are. Okay? And as professionals, we understand the disorder, and we think we have something that we can do to help, as opposed to, I don't even believe in that diagnosis in children, which we've heard lots of. Okay? Building skills. If you do any meta-analysis of couples or family therapy, what are the active ingredients you come back to? Problem solving and communication skills. Nothing new here. We're doing that, but we do it in the service of symptom management. How do you talk about problems in a way that can solve how to manage the symptoms? Treatment goal, you've heard that expression, if you give a man a fish, he will eat for a day. If you teach a man to fish, he will eat for a lifetime. Now, we don't believe that 8 sessions of MFPEP or 16 to 24 sessions of IFPEP are the lifetime of therapy that you need, but we think it's a pretty good starter kit. We think that by the time you've finished a course of MFPEP or IFPEP, you've probably gotten the fundamental concepts that you need to keep working on as you go through various developmental phases or as you continue to work with an ongoing therapist. What are the pros and cons of MFPEP? There's tremendous peer support, as I've suggested, for both the children and the parents. There's in vivo social skills training. So we have the kind of check-in at the beginning, then we do the review preview, we do the lesson of the day, and then we have an activity. And the activity is gross motor. It's moving around. These kids were running group from 5 to 6:30 at night. It's a weeknight. Most of them have ADHD. Most of their stimulants have worn off. These are an active bunch of children, okay? So we are doing in vivo social skills training. Many of these children are the pariah of their local elementary school, and suddenly they're amongst their own, and it feels really good. The kids come in kind of mopey. By the time they leave group, they come up from, in our case, we have a gym. They come up, they're laughing, they're giggling, they're high-fiving each other. They're like, and the parents are, what did you do to my child? I like it, but what did you do and how did you do it? And could I do that at home? Because the kids really look different after having a positive social experience, which is not what they usually are getting. Parents and kids can learn a lot from each other. We as therapists can say something, but it's a lot more powerful when another parent in the room gives the message that we were wanting to give therapeutically. So it's very powerful when a parent can share a positive anecdote with another parent. Same thing with the kids. What are some cons? You can't tailor-make treatment for the specific needs of a child or parent. In an 8-session group-based intervention, it's kind of lock, stock, and barrel. Here's what we do session 1, here's what we do session 2, et cetera, et cetera. You have to really consider attending to group dynamics when you're selecting members. You don't want one family out in the lurch. If you've got a bunch of high-income families, you don't want one low-income family. They're going to feel out of place. If you have mostly low-income families, you don't want one high-income family that's like, I can't relate to your problems. You know, getting in the food stamp line is not my issue, but getting the right private school is my issue. These people are not going to particularly connect. So you don't want anybody totally left out in the lurch. You don't want only one girl in a group of boys. You don't want one really mildly impaired kid with a bunch of severely impaired kids. We had a few dropouts in our clinical trial because we had a couple of kids with mild depression who somehow got into the study, and they look around the other kids, it's like, I'm not like that. And they were correct. They weren't like that. And they felt really like, I'm not a part of this group. So they came out. Okay. And it's harder to schedule for families because you've got to come in at this time and there's no flexibility. If group is Tuesday 5 to 6:30, group is Tuesday from 5 to 6:30. And if that doesn't work with your work schedule, group is Tuesday from 5 to 6:30. You know, so it just may or may not work. So obviously you don't get a lot of flexibility. What are the therapist requirements for MFPEP? The parent and lead child therapist need to be familiar with mood disorders. It shouldn't be the first time you've ever thought of the concept. You need to understand kids and families. This isn't the time to say, I've never worked with a family before, now let me work with a bunch of them all at the same time. That'd be a little overwhelming. And you should have some sense of group therapy, kind of how to balance the needs of a group, don't let one person monopolize, etc., kind of those standard group therapy principles. The child co-therapist has to be familiar with behavior management. It's a great role for a trainee because they don't need to lead the content, but you would never want to have 5 to 8 kids in a room with only one therapist. I wouldn't want to, not our kids. We've had kids who've needed to be escorted to the emergency department to be hospitalized during the middle of a session. We've had kids who've needed to be one-to-one out in the hallway. Anybody needs to go to the bathroom, you don't want them doing that on their own, you know, got to be escorted there, you know, so you need a second therapist. What are some additional features of MFPEP? We use a point system. These are 8 to 12-year-olds. Point systems work like a charm. We love them. And we accumulate points in a couple of ways. Each session, they can get points for participation in completing their projects, doing their breathing exercises. And then we do a review game, kind of like Jeopardy, at the final session, and you get lots of points. And if you get on the daily double, you get twice as many points, and it's so exciting. So then you get all those cumulative points, you cash them in, and we have a nice little prize bags at the end that you get to pick your prizes out of to get your points. We also use immediate reinforcers like Starburst if there's no little food allergy issue or braces issue, something that you can do that you can just intermittently throw out when somebody's doing a great job of participating. Kind of a standard stuff that you would do with 8 to 12-year-olds. We had an interesting discussion, I don't remember if it was over lunch or dinner, but there's what are the active ingredients of treatment? And then what's all the stuff that goes into just being a good therapist? Like if you fundamentally don't enjoy being with children, don't be a child therapist. You know, bad idea. But it's all this extra stuff that we rarely talk about when we talk about manualized treatment that really matters. Like if you can't just connect well with a variety of kids, you shouldn't be running this group. okay? And that's the stuff we tend not to talk about when we talk about manualized treatment, but it is critical. It's the spoonful of sugar that makes that medicine go down. Okay, so how do we start every week? We do a little news, and kids get, parents and kids are together, then we bring the kids over to their own room, or vice versa. Kids have to settle in and kind of get to know each other. So we do a little news of the week. Everybody can share 1 or 2 items, highlight of the last week. I just got a new hamster, my best friend moved away, whatever the news is, that's their time to share. And then at the end, we do those games that I talked about that are thematically linked to whatever the topic of the day is, and it's a chance for in vivo social skills training. You want to think about group composition. We've talked some about that. The therapist workbook, in addition to what you get just of the actual exercises, we have a nice therapist manual. It gives lots of little tips, the keep in mind tips, the leader tips, examples, games, the posters that you use to put up in the room, page prompts for the child workbook. What are some pros and cons of IFPEP? You can very flexibly administer the treatment modules. If for some reason a kid comes in, you've just finished the assessment, the family's ready to start IFPEP, and they're about ready to blow up at school. They've never had an MFE, there's no 504 plan, there's no IEP in place, and school is about ready to fall apart. You probably want to go straight to that school module. You probably don't want to start with anything else. You just need to get right in there and manage crises, okay? They're also in the bank sessions that you can use flexibly to meet the needs of the family. So that's, again, you get a lot more flexibility, which is what happens when you work with one family instead of a whole group. We include a unit on healthy habits, on siblings. So we bring siblings in if there are siblings in the family, if there are any issues whatsoever, which there almost always are if there are siblings. And then we have a session where there's contact with school professionals. Again, the in the bank sessions allow for repeating sessions if you need to do a little bolstering of a concept, or you can augment treatment. A family that we've just started an IFPEP, there was some concerns about abuse, and so we did a little extra work around the abuse at the very beginning. That was an in the bank session that was used as the first session. Okay, so you have that kind of more flexibility built in. It's obviously easier to schedule. If Tuesday from 5 to 6:30 doesn't work, come up with another time. Much easier to make that work. But you don't get the cons. You don't meet other people struggling with the same issues. And I think in every supervision session we had, for every session we ran in our clinical trials, we would meet post-group and kind of dissect what happened and go over all the details and figure out where we, was there fidelity to the model, et cetera. And I think in every single group processing session, we talked about the power of the group, where there's something that happens magically in group therapy that you kind of just don't do when you're working one-on-one with a family. That we absolutely were committed to that group model, for as difficult as it can be to arrange for a group of kids all to meet at the same time. And the social skills training with peers is not available if you don't have other peers in therapy with you. But you only need one therapist, and that therapist only needs to be familiar with mood disorders and kids and families, so it's easier to pull off. Definitely easier, but you miss that magic of the group. Okay, I'm going to briefly talk about resources, and then we're going to switch over and go through the therapy manuals and kind of nuts and bolts-ish walk you through how we do the treatment. But I had alluded to earlier clinical trials. I would think anybody, when you're helping families access care, if in whatever community you are in, if there are clinical trials going on, it's a great way to get families into very obsessional assessments, where then hopefully in our setting, whenever we do an assessment, we gladly will pass that report on to any clinician or any school professional that they ask the reports to go to. So I'm a huge believer in encouraging families that you're not just being a guinea pig if you do a clinical trial, but you are being tested in state-of-the-art treatment to see if it will be state-of-the-art. And if nothing else, you should be getting in any clinical trial you participate in a really fabulous assessment, and then you should be very assertive and ask for those results to be sent to wherever you want. So I really encourage families to consider participating. It's also how we push our knowledge forward. We can only do that through studies. So we have 2 studies we've just started, our OAT studies, omega-3 and therapy. 60 kids in each trial. It's a 12-week study, 8 to 14-year-olds. Protocols are identical, except the first study takes kids who are depressed. The second study takes kids with BPNOS or psychothymic disorder. And they can't have had meds or psychotherapy in the previous month. 3 years from now, you'll hear the results of this trial. I have no results right now. We're just enrolling kids. We're up to 4 kids between the 2 trials. They can be on stable stimulants or sleeping aids. They'll get omega-3 or placebo. They'll get IFPEP or active monitoring. So there you see those studies. Lots of books. These I could not have shared with you 10 years ago because they weren't written. But now we have lots of books that are available for kids, books that are more appropriate for teenagers. And these are all in your handouts. I'm just going to kind of scroll through this. This book I really like for kind of the late preteen, early teenager. It's if any of you read the Grimm's fairy tales, this is a great variation on one of the Grimm's fairy tales, what the experience is like for a young adolescent girl with bipolar disorder. Books for parents, and again, educating parents I think is critical. And then if parents themselves have a mood disorder, strategies for them. An Unquiet Mind, which is an absolutely exquisitely beautiful autobiography of Kay Jamison, who is a famous researcher in adult bipolar disorder, describes what it was like. She describes, it brought tears to my eyes. Now I'm a little bit of an emotional person, but I absolutely was crying reading this book. As she described, she said, lithium saved my life. I would have committed suicide without lithium. But then she talks about the role of psychotherapy in her life. And when she had given up hope on herself, her therapist had never given up hope on her. And it is a reminder, we don't know how powerful we are in the lives of others. And we need to stay very humble and cognizant of that. Sometimes we might be the only lifeline, and we just need to know that and act accordingly. Miklowitz has a wonderful book for adults and now also for adolescents with bipolar disorder. And then some of my favorites, because kids with bipolar disorder also have general kind of issues. So books about medications, other psychiatric disorders, general parenting. Almost all kids with bipolar disorder will have some kind of bumpiness at school, and here are some lovely resources for school-based interventions and strategies. natsap.org is one of my favorite websites for helping families if they need to get connected to residential treatment or therapeutic boarding schools. And then lots of groups, national support groups, Families for Depression Awareness. If you are working with teenagers or adults who have mood disorders, depression or bipolar depression, there's some very nice workbooks that families can order online for free that are very helpful. CABF is an absolute lifesaver for families who have kids with bipolar disorder. It's a great education and advocacy site. JBRF also has, for those of you interested as psychotherapists, they have a psychotherapy listserv. BP Children is run by Tracy Anglada, who has several of the books on this listserv and absolutely fabulous little newsletter that comes out for kids. And we've talked some about light therapy, nutrition therapy, and there are some resources for that. Evidence-based treatments, I would encourage families to go to effectivechildtherapy.com, and to get PEP workbooks, you go to moodychildtherapy.com, and there are some of the resources. And with that, now we're going to switch over and talk about specific treatment details.